Good afternoon. I'm Theo Arvanitis. I'm at the Institute of Digital Healthcare at the University of Warwick, at the Warwick Manufacturing Group, but also the Warwick Medical School. And I would like to present to you a new project that has been funded under the Horizon 2020. It's only 5 months old, so it's a very embryonic stage at the moment, trying to address a very serious problem in terms of multimorbidity and polypharmacy issues in chronic diseases. I'll start a little bit about the current challenges we have in health, and this is what the Global eHealth Group and the Commission for Investing in Health has looked at for the next 20 years, more or less. And actually, a lot of work has happened until now in infectious diseases globally, but the global burden of disease has moved a little bit further down to non-communicable diseases, and actually the ones that they are chronic. So although we have a few unfinished elements in the agenda like child and maternal deaths and some infectious diseases, you'll be pleased to hear that malaria is becoming not the number one health problem anymore, and other problems like cardiovascular and diabetes are the problems not only of the developing world, but the developing world. And of course, all of this affects very much the way the healthcare system works, and it is burdened financially. So, as part of this issue, we can see that chronic diseases, especially in Europe, account not only for the 70% of the healthcare expenditure, but also affect over a third of Europe's population. And not only they affect the daily quality of life in terms of poor health, but they affect the activity of individuals. So this is how we define multimorbidity as including the accumulation of chronic diseases that have a number of functional and cognitive impairments for individuals. And it's very interesting that as we get older, as this is a session talking about elements of integrated care and aging, at least 3 chronic conditions exist in people, and it's not uncommon now to treat people with 5 chronic conditions altogether. So the clinical management of these patients is really very complex. Not only is time consuming for the system, but it is complex in terms of how we follow up things, not only at the level of care, but also at the level of everyday activities. So, at least in the UK, where we have the combination of healthcare system and social care system, the support of these individuals, the support of the citizen, who is a patient as well, is very, very complex. And a lot of effort is happening from the informal carer, but also community care services. However, we experience a lot of shortcomings in terms of delivering this between the social and healthcare systems. And within each system, these problems exist. And I dare to say, and this is a big discussion we have in the NHS in the UK, the financial burden is really, really difficult and very complex. Actually, even for mental health in the UK now, we have the problem of the burden of not being able to discharge patients from hospitals because we don't have enough places in care homes and secondary kind of follow-up of these individuals. So this is very, very complex. Now, this is how Europe would like to see things happening in the future. And indeed, at the moment, a lot of these people are treated at the acute side of the healthcare system, and of course, at the primary care approach, and very little happens at the community level. As we are progressing, and as we started the project this year, and when we were writing this grant and proposal to the Commission, we noticed that again, still no change. Our aspiration is by 2020 that the acute-based approach is diminished, and a lot of work happens at primary care level and community care. So to achieve that, we need to take a different approach to the concept of integrated care. At the moment, things are siloed, and we need to change that. So there is no single model to the concept of integrated care at the moment. But at least, as a definition, the management and delivery of health services so that citizens receive a continuum of preventative and curative approaches to care is what we would like to look as part of integrated care. And we don't see people reactively when they become ill, but we need to see people throughout the continuum of their health and well-being. So this is important to coordinate it. And of course, if we have a digitally enabled approach, as this is the kind of thing we have here in this forum, we can have more adaptive and radical solutions. So the project we are proposing takes the benefits and the opportunities that healthcare has seen through technology. And here just list, for the purpose of the discussion of the work of the project, the main benefits we have seen across the healthcare enterprise. So linked care, linked information is very important in supporting the delivery of care. Electronic healthcare records, at least in the Western Europe, are becoming extremely useful. Not only that, they support care, but also we can harness the data so that we can make better decision making at an individual level so that we can achieve effectiveness and patient safety, but also at a public health level where we can achieve consensual public health decision making. Furthermore, we have seen the development of a variety of tools for remote monitoring and self-management. The previous presentation showed an example of that. And this gives empowerment to the individual, to the citizen, to take responsibility for their care. Of course, the digital approach changes the approach we see people, we care for people. So examples like online consultations or interventions online change the approach we run our healthcare systems. So now we have new models, and this changes a lot. And of course, we can have new ways to harness and collect more information and monitor physiological parameters. I think the digitally enabled approach is great. It has a lot of opportunities and a lot of challenges. And I don't separate them, I put them together. So here are these opportunities and challenges. To link data is great. We can integrate data. We can provide insights to the whole patient pathway. However, the appropriate integration, interoperability is something that we have been working technically, but now we need to understand more in terms of policy and meaning of that data at a different level. So integration, interoperability is still a big challenge. Of course, understanding the complexity of the disease is something we haven't solved, and we need to have better quality data and access to this data and evidence in a different way. And of course, the challenges of governance and privacy come into that opportunity as a burden. Knowledge empowerment of the citizen is essential. However, how many of us are prepared to manage our own disease? How many of us are equipped to do that management? So building awareness is an opportunity through digital means. However, it is still a challenge to reach everybody in the community. Of course, this gives us the opportunity for having choices to support care and creating communities which are slightly different from the communities we're used now. And of course, this can be improving the way we have contact with the healthcare system, where telecare services are not something of science fiction, but is an everyday approach. So this is what C3-Cloud aspires to do, and as I said, we are on the 5th month of the project. We started 1st of May, and it is about an ICT infrastructure. However, it is a very pragmatic approach to the project we follow. We try to create that continuous coordination of patient care activities, and as part of that, we have facilities to allow the collaborative creation and execution of care plans, which are stratified, personalized, medicine-based. We give decision support in terms of the risk prediction and stratification, reconciliation and recommendation of guidelines, and do the polypharmacy management. We fuse multimodal patient and provider data. We put meaning in the data, so we do semantic interoperability, and we have active patient involvement. Now, we do this over a variety of comorbidities. In particular, we looked at triplets of comorbidities in terms of diabetes, heart failure, renal failure, and depression. And we're going to do this in 3 European regions, which I will talk in a minute, in large populations. So these are the partners, a couple of universities, kind of NGOs and institutes of research in Europe, and some of these are well known to this forum, companies that provide records and decision support systems, and of course these are the most important partners, the 3 regions where the pilot studies are going to happen, and they're already happening at a small scale at this stage in the project. So South Warwickshire, a small region where we have an aging population, the Basque Country area where they have done a proper integration of their healthcare record system, and we have a larger population, and an interesting region in Sweden where we have a combination of dense urban and very sparse rural areas, and we have different approaches in the way we treat the patients there. I'm not going to go through this, but we are very ambitious, and these were the specific challenges that the Commission has done, but most importantly, what we want to achieve at the end is to achieve that informed participation of patients in the care management, create better care efficiency plans, and do co-production not only with patients but all stakeholders. So for the first time, this is one of the projects where I have minimized as a coordinator the number of universities. So we have only 2 universities, and the rest are SMEs, large companies, and regions or NGOs. So that makes a big difference in the way we look at that. This is the overall architecture. This is what we try to aspire to provide as part of the platform, and I will talk about it in some more detail. And here is some of the technical aspects of that architecture. Let me just blow it up a little bit so you can understand it. So as part of the tools we want to provide for the multidisciplinary care team that doesn't include only healthcare professionals, but broader stakeholders, dietitians, social care professionals, people in gyms that take care of people with cardiovascular and diabetes where they need to do exercise as part of their treatment, and the all formal carers. So a platform that allows to create personalized care plans and also deliver them in a coordinated approach between primary care, secondary care, acute care, and community-based care, but also a platform that allows the patients to communicate directly with the MDT and negotiate their self-management. And of course, as part of that, because we are having patients which might not have, which might be very restricted because of the advance of their disease, we include the informal carers who play a very important role. And all of this is supported by clinical decision support systems, as I discussed. So as part of the care plans, we use decision support systems from one side to be able to understand all conditions and concerns, and through the patient status to identify potential direction in the treatment plan or the management, but equally to and identify different interventions on that, but equally to identify specific goals that they are negotiated with the patients in the same way that the entity negotiates these goals, so that we achieve progress in the management of disease. The other interesting thing is, as I said, the complexity. So this is our first exercise in the Basque Country where we look at care pathways for a multimorbid patient with diabetes, and actually in different levels of care. So what we try to do is connect these levels of care. So if we see the patient, a stable patient at the hospital level, or an unstable patient out of hospital care, a discharge exercise, and in hospital care, we can see the interactions through the different pathways, include a lot of actions, complex actions, and a lot of interchange between the different approaches. So rather than silo this, we try to create models, and our first delivery in the project is these particular models, which are in the process of being implemented in the Basque Country. And of course, as part of the effort, we need to do what we do in eHealth, is put the technology in place in terms of technical interoperability, connect the information from electronic healthcare records, social care record systems, community care record systems and telemonitoring devices with personal healthcare records in terms of technical interoperation, which we have achieved already in the field, but we need to pragmatically make it work through semantic interoperation and, of course, by following the complexity of the privacy and information governance laws we have across Europe. And we try to do it in a uniform way, which will be the challenge. So at the end of the day, we hope to have this kind of modular approach of a variety of tools that allows the MTT to communicate better between themselves and the patients, to have clinical guidance and reconciliation of guidelines so that they can create appropriate pathways to organization and care delivery, to connect pragmatically the information systems, and of course give empowerment tools to the patient and formal carers to achieve self-management for multimorbidity and polypharmacy challenges. So that's the aspiration of the project. So in summary, digital enabling integrated care is the way forward in our view, and the benefits are to individuals and society are multiple. Most important is that we can better understand and have appropriate lifestyle choices and promote this for the individual and improve the way the whole society can work and the healthcare system not to be burdened financially and also in the delivery of what it tries to achieve. And of course, to reduce avoidable deaths that can be prevented. In my region, where the University of Warwick is, in Coventry, diabetes is the biggest killer of the population. And it is a real burden. We have so many diabetics that if you were an epidemiologist in diabetes, this is the right region to do any research. But it's sad to say that. So we hope that in 5 years' time, I might be out of the job and we have reduced the number of deaths and the effect of the disease, but that might be wishful thinking. So that's really what we try to do with C3-Cloud, and we hope that at least we do the first step to better enabled integrated care for Europe. Thank you for your attention.